Hi guys, welcome back. As usual, we're going to start with a question. So, a 7-year-old boy is brought to the pediatric clinic because of progressive abdominal distension and recurrent fevers. His parents report he has had frequent episodes of lymph node swelling, so lymphadenopathy, since early childhood and a recently developed easy bruising and fatigue. This examination reveals generalized lymphadenopathy and splenomegaly. Laboratory study shows a persistent elevation in double negative T, T cells and autoimmune hemolytic anemia. Bone marrow biopsy shows no evidence of leukemia. Genetic testing reveals a defect in FAS receptor, which is involved in the extrinsic apoptosis pathway. Which of the following condition in this patient most likely develop? So based on the history of what appears to be an autoimmune disease, and with the genetic testing revealing problem with the FAS receptor that's involved in the extrinsic apoptotic pathway. So I think the best answer here would be autoimmune lymphoproliferative syndrome. So let's see why. So today we're going to be, so over the past few lectures that we did in the past, we've been talking about cell death and we've been focusing on necrosis, and we've covered different aspects of necrosis. And if you have not watched the video on necrosis, I strongly encourage you to watch this video on necrosis. But today we're going to be focusing on another type of cellular death, and which is apoptosis. So let's discuss apoptosis. So what's apoptosis? It's a programmed energy dependent form. So in other words, it's going to be using ATP form of cell death, which is characterized by cell shrinkage, chromatin condensation, formation of apoptotic bodies. And the most important thing is that no inflammation is involved. Remember, as opposed to what we saw with necrosis, whereby necrosis involves inflammation. But with apoptosis, there is no inflammation involved. And when we look at apoptosis play a major role in both physiologic and pathologic processes. Remember, as opposed to necrosis, necrosis is always pathology. So necrosis is always pathology, but apoptosis could be involved both in physiology or pathology processes. So let's see example of these physiologic roles of apoptosis. So one, apoptosis is involved in embryogenesis and tissue remodeling. So for instance, the organ development and remodeling, remember the other day we discussed about cardiac remodeling. And if you've not watched that video on cardiac remodeling, I strongly encourage you to watch that video on atrial septation. So it's involved in those cardiac chamber formation is the job of apoptosis. Development of inner ear, right, is also the job of apoptosis, and the removal of webbing between fingers and toe is also a job of apoptosis. Apoptosis is also involved in regression of Mullerian ducts in male fetus due to Mullerian inhibitory factor that is produced from Sertoli cells. And that's why if there's a failure of this, then that patient could develop what? They could have both male and a female structures, right? Reproductive structures. Moving on to the next one, which is hormone-dependent tissue involution. So the monthly shedding of endometrium is also related to what? Apoptosis. So endometrial shedding during menses after progesterone withdrawal is always also related to apoptosis. Atrophy of the breast after menopause and a cessation of breastfeeding is also another example of um, apoptosis. So next is normal aging and immune function. So the timing, because when we are born, you can see on the chest X-ray, you're going to see a big thymic shadow. But as time goes on, what happens? Those timing become very smaller to the point you can't even see them anymore. So that thymic involution with age is also through the process of apoptosis. Normal turnover of labile cells, for instance, intestinal epithelium, is also related to apoptosis. So now let's focus on the pathologic roles of apoptosis. So what are the pathologic roles of apoptosis? So the first one there is the cytotoxic T cell, which is our CD8 mediated killing. So the way the cytotoxic T cell kills, it actually kills by using apoptosis. So for instance, if it's killing destruction of tumor cells, right, or killing of viral infected cells. So if you have a viral infected cell, what's going to kill it is going to be your what? Cytotoxic T cell. And of course, if that cell failed to express MHC class 1, right, who is going to do the killing? Very good. Natural killer cells will do the killing. So with the killing of the virus infected cells, so at the end of the day, you can form what they call consumer bodies. And these consumer bodies are basically a apoptotic body, which we see classically in what? Viral hepatitis, as we're going to see later. The next example under pathologic role of apoptosis is immune dysregulation. So for instance, after transplant, right, after organ transplant, one of the complications of organ transplant is graft versus host disease, whereby the graft, which is immunocompetent, is rejecting the host who is immunocompromised. And that could lead to graft versus host disease. And those are the patients that normally present with classic what? Diarrhea, dermatitis, hepatitis. So if you see a question on somebody just had the organ transplant and now they're developing diarrhea, dermatitis, hepatitis, elevated liver enzyme, always think about graft versus host disease. And that's when the graft is immunocompetent, but the host is immunocompromised. So the immunocompetent graft is rejecting the immunocompromised host. Next is autoimmunity from failed negative selection. As we're going to see when we get to immunology, when we start talking about positive and negative selection that takes place in the thymus. Because remember, the T cells are produced from the bone marrow. So they are made from the bone marrow. And then once they leave the bone marrow, before they become mature, they have to go to the what? To the thymus. So they go to thymus for maturation. And then for them to become mature, they have to go through what we call positive selection and negative selection. And what does positive selection mean? It means that those T cells that they are able to recognize self antigen. In other words, they are able to recognize us. We allow them to live, right? So they move on to the next step, which is going to be what? Negative selection. And in negative selection, those T cells that they have very strong affinity for self antigen. In other words, they recognize self antigen too much. Those T cells, we're going to kill them. We're not going to allow them to survive, because if you allow them to survive, they're going to lead to autoimmune disease. And how do we kill those T cells that fail negative selection? It's going to be through the interaction between the fast and the fast ligand interaction, which is also part of the extrinsic pathway that we're going to see in apoptosis. So that's why if there's a defect in that fast to in the interaction between the fast and fast ligand, then that could lead to autoimmune lymphoproliferative syndrome, which is what we saw in that question. So that question we saw earlier was a failure of interaction between the fast to fast ligand interaction, leading to autoimmune lymphoproliferative syndrome. Also, apoptosis of activated lymphocyte after withdrawal of interleukin 2. As we know, one of the major functions of interleukin 2, it causes proliferation of the lymphocytes. So it stimulates the lymphocyte proliferation. So if you withdraw that interleukin 2 from those proliferating lymphocytes, then they're going to undergo apoptosis, right? And that's the role of how we use most of the immunosuppressive therapy. So that's how most couple of the immunosuppressive therapy, that's how they work. Most of them, they are targeting the interleukin 2 to decrease interleukin 2. A classic example there is our corticosteroid. So if somebody is taking corticosteroid, that could decrease the interleukin 2, and by suppressing interleukin 2 production, then that will induce lymphocyte apoptosis. And just a side question, what's going to be the effect of corticosteroid on neutrophil and eosinophil? Very good, right? Remember, if you have corticosteroid on board, your lymphocyte is going to be decreased because of the apoptosis. Your eosinophil is going to be decreased. Very good, because of sequestration in the lymph node. What about neutrophil? Very good, it's going to be increased. So neutrophil is going to increase. And why? Because corticosteroid inhibits adhesion molecule. So by inhibiting the adhesion molecule, those bound neutrophil will become what? Circulating neutrophil, and that could lead to neutrophilia. And that's why if patient is undergoing stress or they're taking corticosteroid, you can see increase in white blood cell due to neutrophilic leukocytosis because of inhibition of the adhesion molecule by corticosteroid. The next example there under pathology apoptosis is pathologic atrophy, right? So like atrophy of endocrine gland when the stimulating hormones are withdrawn. So for instance, as we know, the TSH is going to stimulate the thyroid gland to make T3, T4. So if you lose that TSH, then that thyroid gland is going to undergo atrophy, which is going to become atrophy. So because of the apoptosis leading to atrophy. Also loss of ACTH. Remember, ACTH normally stimulates the adrenal cortex. So if you lose that ACTH, then that could lead to what? Adrenal gland atrophy. So causing apoptosis leading to atrophy. Also loss of FSH-LH, right? So if you lose FSH-LH, then that's going to lead to decreased stimulation to the ovaries, and that will lead to apoptosis in the ovary, and that will lead to atrophy. So that's why if somebody is taking exogenous thyroid hormone, so if somebody is taking exogenous thyroid hormone, as we go to see when we get to endocrine, this will negative feedback, right, to the hypothalamus and pituitary. So in the hypothalamus, it's going to decrease your TRH, thyroid releasing hormone, and that will lead to decrease TSH, right? And then because of the decrease in TSH, that will lead to decreased stimulation to the thyroid gland, and that will lead to apoptosis of those thyroid tissue, thereby leading to what? Atrophy. Very good. Also atrophy of the prostate after orchiectomy. Why? Because if you remove the testes, right, so there will be no what? There will be no androgen, right? And one of those androgen is going to be what? DHT, right? Dihydrotestosterone. And this dihydrotestosterone is what normally stimulates what? The prostate. So that's the idea when people have disease like prostate cancer, whereby we recommend removal of the what? Of the testes, because we know once you remove the testes, that will decrease the androgen, that will lead to decrease in DHT, and that will lead to less stimulation of the prostate, and that will lead to apoptosis of those prostate gland, thereby leading to what? Atrophy. Very good. Another example is DNA and protein damage. So for instance, if somebody is exposed to radiation, free radicals, remember we spoke about free radical injury the other day, We also spoke about hypoxia. So if you guys have not watched those videos on free radical hypoxic cellular injury, please do watch those videos. It's going to really help you. So radiation, free radical, toxin, severe hypoxia, all these could lead to DNA damage or protein damage, and that could lead to activation of what? Apoptosis. So amyloid deposition in the tissue, like in the case of Alzheimer's disease, that will also lead to what? Activation of apoptosis, right? So moving on, guys. So excess apoptosis also contribute to other diseases. So diseases like sepsis, right? Acute myocardial infarction. Remember, with acute myocardial infarction, necrosis could also be involved, right? And then what type of necrosis? Very good, coagulative necrosis. But apoptosis could also be involved. Neurodegenerative disease, like things like Parkinson's disease, Alzheimer's disease, there's apoptosis is also implicated. And type 1 diabetes mellitus. Remember, with type 1 diabetes mellitus, is an autoimmune destruction of those beta cells, whereby your cytotoxic CD8 T cells are being involved, causing what? Apoptosis of those beta cells. And that's why with type 1 diabetes mellitus, if you destroy the beta cell, there will be no beta cell to make insulin. That will lead to insulin deficiency. So now let's move on to talk about mechanism of apoptosis. So mechanism. So when we look at the mechanism of apoptosis, there are two ways whereby this that the apoptosis could proceed. So it could proceed through the intrinsic pathway or extrinsic pathway. So the apoptosis could proceed through intrinsic or extrinsic pathway. But regardless of either intrinsic or extrinsic, there is one goal. The goal of this of apoptosis is to activate caspases. So their goal is to activate caspases, and that caspases is what's going to do the what? Execution of those cells. So let's start with the intrinsic pathway. So this intrinsic pathway is also referred to as mitochondrial pathway. And this intrinsic pathway could be activated by maybe DNA damage, misfolded protein, which is amyloid, right? So example of misfolded protein is amyloid, oxidative stress, right? Viral infection, and a lack of survival signals. So any of these could activate the intrinsic pathway. And when you look at the intrinsic pathway, the key mediator there are what we refer to as BCL2 family protein. BCL2 family protein. And these family proteins are divided into two. We have some of them that are anti-apoptotic, right? In other words, they inhibit apoptosis, right? And then we also have the one that are pro-apoptosis, so meaning that they activate apoptosis. So the one that inhibits apoptosis include the BCL2 and the BCL-SL. And the one that will activate, which are pro-apoptotic, those are BAS and a BAK, right? And so how do they activate apoptosis? So when you look inside the cell, right? So let's say this is our cell. So inside the cell, we have the mitochondria, right? So we have the mitochondria. And inside this mitochondria, right, there's an important chemical there, which is what we call cytochrome C. So this cytochrome C is present inside the mitochondria. And you don't want this cytochrome C to leave the mitochondria unless the cell wants to undergo apoptosis, right? So this BCL2 and a BCL-SL, they preserve the mitochondrial membrane. So they maintain the integrity of this mitochondria so that this cytochrome C does not leave the mitochondria. As opposed to this pro-apoptotic gene like the BAS and the BAK, they causes what? They causes permeability of the mitochondria. And then once the mitochondria become permeable, then this cytochrome C is going to move from there and move to the cytosol. And then once it gets to the cytosol, it's going to now activate caspases. And then once it activates caspases, then that will lead to what? That will lead to apoptosis, right? So let's see here. So if you look at the mechanism, so increase BAS and BAK, right, leads to increase in mitochondrial outer membrane permeability. And because of that, the cytochrome C will be released into the cytosol. And this cytochrome C is going to bind to APAF1, and that will activate caspases, and that will lead to what? Execution of those cells, right? So let's look at DNA damage. So let's just take a DNA damage for an example, right? Because remember, we mentioned a couple of things that will activate this intrinsic pathway, and then one of them is DNA damage. So let's say let's say somebody, the patient is exposed to radiation, and because of the exposure to the radiation, there is DNA damage. So if there's a damage to the DNA in the cell, guess what 53 is going to do? Remember, 53 is a tumor, it's part of the tumor suppressor gene. So what's this p53 going to do? Is going to arrest the cell in the cell cycle. And then once they arrest the cell in the cell cycle, what's it doing? It's allowing for repair of those DNA damage, right? And if we can repair the cell, if we can repair the DNA, or if the damages to the DNA is too much, is so severe that we can't repair it, then guess what p53 is going to do? The p53 is going to activate the pro-apoptotic gene, which is BAS and BAK, right? And it's going to inhibit the anti-apoptotic gene, which is BCL2 and a BCLXL. So this pro-apoptotic gene, the BAX and BAK, are going to now cause what? Mitochondrial permeability. And that will allow the cytochrome C in the mitochondria to be released into the cytosol. And this cytochrome C is going to activate what? Caspases. And that's going to lead to what? Apoptosis. Very good. So that's the intrinsic pathway. So what are some pathology that we need to know for the exam that they may ask us, some clinical correlation that they may ask us in the exam? So one is follicular lymphoma. So follicular lymphoma, as we know, is due to translocation 14-18. And how do I normally remember this? How do I remember that follicular lymphoma is also with translocation 14-18? Because follicular F is F for 14. So that will be 14. And if you count how many alphabets in this follicular lymphoma, they are all 18. So 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15, 16, 17, 18. So that's how I remember that follicular lymphoma is translocation 14-18. And in this follicular lymphoma, there is increase in overexpression of BCL2. So overexpression of BCL2. So that means if you are overexpressing the BCL2, that BCL2 will continue to maintain the integrity of the mitochondrial membrane, thereby preventing cytochrome C from coming into the cytosol. So in other words, that will decrease what? Apoptosis. And this is a tumor survivor. So that will allow the follicular lymphoma to continue to what? Grow. So that will lead to tumorogenesis. And the other example here is going to be in the case of mutation of p53. Remember, we just mentioned that p53 is an important tumor suppressor gene that normally helps to arrest the cell in the cell cycle to facilitate what? Repair of the damaged DNA. And if you can't repair those damaged DNA, then there's going to be activation of what? Apoptosis, to be able to kill those damaged cells. And that's why mutations in p53 have been seen in a lot of cancers, and is also classically related to what? Leigh-Fraumeni syndrome. So Leigh-Fraumeni syndrome is a condition whereby the patient has multiple malignancies. So the same patient could have sarcoma, lymphoma, squamous cell, multiple cancer at the same time. So if you see a question on the exam whereby they're describing a patient who has multiple malignancy, always think of Leigh-Fraumeni syndrome related to mutation in p53 tumor suppressor gene. So moving on to the extrinsic pathway. Remember, we just spoke about intrinsic, which is also called mitochondrial pathway. So moving on to the extrinsic, which is also referred to as death receptor pathway. So this could be triggered by three mechanisms. So one is the interaction of Fas with Fas ligand. So the interaction between both of them. And this Fas receptor, the CD marker for it is CD95. So make sure you remember that. So when you look at the Fas receptor, the way I know that it's a Fas receptor is that I see the marker on it. And the marker for that Fas receptor is CD95. Just like when you see B cell, what's going to be the marker for B cell? Very good. CD20, CD21. Just when you see T cells, right? What's the CD marker for the T cell? Very good. CD3. And if it's TFR cell, then you go to see what? CD4 in addition to CD3. And if it's cytotoxic T cell, you go to see what? CD8 in addition to CD3. So just same thing for this receptor, then the marker for it is CD95. And if Fas ligand is released, that Fas ligand could bind to this Fas receptor, and that could also activate what? Apoptosis. So that's one mechanism. The other one is the interaction between the TNF alpha, so tumor necrotic factor alpha, binding to the TNF alpha receptor. So that could also activate what? Apoptosis. So if you look at, remember another name for TNF alpha, we also call it what? Cachectin, right? Remember when you say something is cachectin, when you say a patient is cachectin, it means that they're losing so much weight, right? So, and this TNF alpha, right, if somebody have chronic medical condition, chronic inflammation, right, so they could be producing tons of TNF alpha, and that is going to be binding to their TNF alpha receptor, and that could lead to weight loss. So this TNF alpha, as we know in the past, we spoke about it in the past, is one of the inflammatory cytokine, right? So acute phase cytokines, which is produced from the macrophage. So it can induce fever, it could cause cachexia, so it could make patients to be losing weight, and it could also cause what? Inflammation. So let's look at the mechanism. So this Fas ligand interaction, right, will lead to activation of the Fas associated death domain, and that could lead to activation of what? Caspases. We also have interaction between TNF alpha and TNF receptor, which is also similar to the death domain signal. And either of them will lead to activation of what? Caspases, and that will lead to what? Apoptosis. So that's two mechanisms. The third mechanism under extrinsic is the immune one. So the immune associated apoptosis, right? And under here, we have our cytotoxic T cell, which is our CD8. And then we have what? Natural killer cells, right? So the way this guy killed, right? So they use perforin and granzyme to cause what? Apoptosis. So if this is a cell, and let's say this cell is infected by virus, or there's a tumor right? In this cell, as we're going to see when we get to immunology. So this cell, because insulin is inside the cell, so they're going to be producing what? Endogenous antigen. And this endogenous antigen, because they are made inside the cell, are going to be what? Loaded into MHC class 1. So they're going to be loaded into MHC class 1. Inside where? Inside the rough endoplasmic reticulum, because that's where the protein is being produced. And this MHC class 1 is going to move to the surface of the cell with the antigen, right? And then it's going to present the antigen, because as we know, MHC class 1 normally presents its antigen to what? Very good, to CD8, to cytotoxic T cell. Remember, as opposed to MHC class 2, MHC class 2 is going to present its own antigen to what? CD8, which is our T helper cells, right? And then the way you can remember is it's going to present to CD4. I'm sorry, CD4. So, and then the way you can remember is 2 times 4, so that would be 8. And then 1 times 8, that would be 8. So that's how you can remember. So MHC class 2 presents its antigen to CD4 T helper cell. And MHC class 1 presents its antigen to what? CD8 cytotoxic what? T cells. So this MHC class 1 with the antigen is going to move to the surface of the cell and is going to present that antigen to what? To our cytotoxic T cell, right? Which is our CD8, right? And then guess what this CD8 is going, this cytotoxic T cell is going to do? Is going to release perforin, right? So that those perforins, right? They're going to punch holes. They're going to punch holes on those cells, right? So they're going to form what? Pores on those cells. And then in addition to that, they're going to release what? Granzyme B. So that granzyme B now is going to now go in through these holes and go into the what? Into this tumor or viral infected cells. And then once they enter, they're going to what? Activate caspases, right? And that's how our cytotoxic T cell is able to kill viral infected cells, right? And remember, this does not involve any, it doesn't involve any antibody. So this is going to be an example of type 4 hypersensitivity reaction. So which we're going to discuss in details when we get to immunology. And moving on, guys. So question for you guys. Let's say this viral infected cell fails to express MHC class 1. So this viral infected cell does not express MHC class 1. Who is going to do the killing? Very good. Natural killer cell is going to do the killing. Make sure you remember that. Remember that. And you're going to thank me later. So moving on, guys. So the FAS is present on the cytotoxic T cells, right? And the interaction of the FAS to FAS ligand is involved in thymic medullary negative selection. Remember, which we spoke about earlier. And that's why defecting the FAS to FAS ligand interaction will lead to autoimmune lymphoproliferative syndrome due to failure of clonal deletion of those T cells that's high affinity for self antigen, right? And that's what we saw in the question that we did earlier. So let's now move on to the execution phase. So once we activate the caspases, either through the intrinsic pathway or through the extrinsic pathway, what's going to happen? So these caspases result in cellular breakdown. So cytoskeleton breakdown, which is going to lead to mitochondrial damage, the cell shrinkage, and the membrane blebbing. And also, they're going to damage the nucleus, right? So they also have endonuclease activity, right? So endonuclease, right? In addition to protease activity. And by those protease is what breaks down those cytoskeleton. That's what breaks them down, right? But the endonuclease, so the caspases also has endonuclease activity. So they're going to break down the nucleus, right? So that will lead to nuclear condensation, which is what we call pycnosis, and nuclear fragmentation, which is what we call what? Karyoesis. And at the end of the day, they go to form what? Apoptotic what? Body. So moving on to the next, which is going to be the final phase. What's to be the final phase? So moving on to the final phase. So in the final phase, what's going to happen? So those cells that die by apoptosis, so now they're going to start, so part of the cell will start to break off, right, to form apoptotic bodies. And those apoptotic bodies are going to be what? Phagocytosed by the macrophages or neighboring cells without inflammation. Remember, as opposed to necrosis, whereby you see inflammation, but with apoptosis, no inflammation. So moving on. So what are we going to see on morphology? So what are the morphology changes when you apply your H and E stain, right? Make sure you guys remember this. You're going to come back and thank me later, because if you don't remember what you're going to see on the morphology, you may not be able to know that this cell actually died by apoptosis. So what are the things I'm looking for? So small, round, eosinophilic, or remember, whenever I use the word eosinophilic, it also means pink. That means the cytoplasm appear pink. And pycnotic, fragmented basophilic nucleus, and a formation of membrane-bound apoptotic body. And then most importantly, no inflammatory cell is present. So that's what you're looking for when you are reading the question and they're talking about the morphology findings. And what about biomarkers? So what are we going to see on biomarkers? So when you do your DNA laddering, so you're going to see multiple 180 base pair. So when the endonuclease is cutting the DNA, when it's breaking down the nucleus and cutting the DNA, is cutting them into multiple 180 base pairs. So that's how you know that this cell actually died by apoptosis. So this is due to cleavage between the nucleosomes, and this is highly sensitive indicator of apoptosis. Guys, I know it's been a long lecture, but we finally come to the end. So let's do some questions. So a 62-year-old woman presents with 4-month history of painless swelling in her neck, right? She denies fever, weight loss. Physical examination reveals non-tender rubbery cervical lymph node. A lymph node biopsy shows a nodular proliferation of small cleaved lymphocytes. Cytogenetic analysis reveals translocation 1418. Anybody remember where we saw translocation 1418? Very good, right? 14 for follicular, and then when you count all the whole alphabet there, they are 18. So follicular lymphoma, leading to overexpression of the BCL2. Remember, BCL2 normally what? Inhibits apoptosis. So which of the following is the direct consequence of BCL2 overexpression in lymphoma? So what do you guys think? So as you know, BCL2 prevents apoptosis by maintaining the integrity of the mitochondria. So as we know, BCL2 prevents what? It prevents apoptosis by maintaining the mitochondrial membrane. So the best answer there will be what? C. So decrease cytochrome C release by maintaining the mitochondrial membrane. Moving on to the next question. A 25-year-old man presents with fever, malaise, elevated liver enzymes. Serologic testing is positive for acute viral hepatitis. Cytotoxic T cells are activated in response to infected hepatocytes. These immune cells induce apoptosis of infected cells using cytotoxic granules. Which of the following most accurately describes the mechanism used by these cytotoxic T cells? Remember, we said that once you have an infected viral cells, right, they express their antigen using MAC class 1. And that MAC class 1 is going to present the antigen to cytotoxic T cell. And the cytotoxic T cell is going to release both perforins and granzyme. So perforin is going to punch holes, and a granzyme B is going to go into the cell and activate what? Caspases. So, and the best answer that will be what? Will be C. But remember, we say if you have a viral infected cells, and it failed to express MHC class 1, who is going to do the killing? Natural killer cell. Very good, guys. Moving on to the next question. A 34-year-old woman presents with jaundice, nausea, dark urine for 1 week. Her AST, ALT levels are very high. Hepatitis serology confirms an acute viral hepatitis infection. A liver biopsy is performed to evaluate the severity of the disease. Histologic examination shows scattered acidophilic or eosinophilic or pink, right, globus representing apoptotic hepatocytes undergoing programmed cell death. What are these structures called, right? Remember, we've mentioned this in the class. These are apoptotic bodies, which are called what? Consumer bodies. So we call them consumer bodies. So they are classically seen in viral hepatitis. Next question, guys. A 55-year-old man presents with severe asthma, hospitalized due to exacerbation requiring high-dose intravenous corticosteroids. 2 days later, lab shows significant drop in circulating lymphocytes. It looks like the corticosteroid is inhibiting interleukin 2. Like we said, remember, interleukin 2 causes proliferation of the lymphocytes. And then when you give them steroid, it decreases interleukin 2, and that lead to what? Apoptosis of those what? Of those lymphocytes. Its neutrophil count is increased. Why? Very good, because corticosteroid inhibit adhesion molecule. So by inhibiting your adhesion molecule, right, so that will lead to what? Increase in circulating neutrophil. But the monocyte and eosinophil are decreased. Why? Because of sequestration in the lymph node. Which of the following best explains the mechanism behind the observed lymphopenia? So I already explained this. So it's apoptosis, right, caused by reducing interleukin 2 signal. And let's go to the last question. A 27-year-old woman presents with concerns about cramping and vaginal bleeding that occur regularly every month. She reported that her menstrual cycles are predictable, occurring every 28 days. On day 1 of her cycle, she undergoes endometrial biopsy for research purposes. Histologic examination shows numerous endometrial glandular stroma cells undergoing cell shrinkage, chromatin condensation, and a formation of apoptotic bodies. No surrounding inflammatory reaction is seen. Laboratory studies reveal a sharp decline in serum progesterone level. Which of the following best explains the mechanism responsible for these endometrial changes that's seen in this patient, right? So like we mentioned earlier, the monthly menstruation is also an example of what? Apoptosis, right? It's actually a physiologic what? Apoptosis. So the best answer there will be what? Will be B. So withdrawal of hormonal stimulation. So we're withdrawing the progesterone. So because the progesterone is falling and is unable to keep increasing the secretion during the secretory phase of the endometrial cycle. So because of those loss of progesterone stimulation, that activates what? Intrinsic apoptosis pathway, thereby leading to what? Shedding of the endometrium. And guys, we've come to the end of today's lecture. Please don't forget to subscribe, like, and share this video with your friends. And I will see you guys in the next lecture. Thank you.